Madam, we are live now. Shall we start?
Yes, please.
So, good evening, doctors. Shuman, on behalf of Shield Healthcare, welcoming you all in today's another interesting session on RH incompatibility and MCA Doppler. With Dr. Dema Suleiman Adwan, madam, and the speaker and the organizer is obviously Dr. Ritu Santwani, madam. It's my honor to introduce Ritu Santwani, madam. Although madam doesn't need any kind of introduction, but I'm just giving few of it. Madam is having more than 20 years of experience, extensive experience in the field of obstetrics and gynecology, along with this cosmetology and IVF. Madam is passionate with this knowledge sharing initiative and many welfare activities as well. She's already attended more than thousands of webinars and knowledge sharing platform and many summits and training awareness program. And apart from that, madam also written more than 200 plus articles and columns in various health journals and newspaper as well. In terms of attachment, madam has many attachment, out of which World Society of Cosmetic Gynecology, WSCG, she is the board member, India, and Middle East Association of Aesthetic Medicine and Reconstructive FGM Surgery, MAM, Vice Chairman, Board of Director. Madam is the director of Pune Test Tube Baby Center and Shamal Clinic. And she is also the panel consultant in the hospital of Ruby Hall Clinic in
Dr. Subman, please introduce our guest. That much is enough.
And with this short introduction, I request madam to take over the session for further follow-ups.
Please show this. Yeah. A very, very warm welcome to our very dear friend, Dr. Dema Adwan. Thank you, Dr. Dema, for joining with us. I know your schedule is very busy. All of you are very busy with ASFMS Academy. I'm really thankful that you have taken out time for sharing your knowledge with all of us. This is a brief introduction of Dr. Dema Adwan. She is head of emergency department of maternity hospital, Damascus University. She is having so many professional skills, excellent skills in the management of normal and cesarean delivery with the management of perinatal diseases and complications. She has excellent skills in approaching infertility with performance of diagnostic and therapeutic procedures. She is having many publications. And very important, what I want to mention here, from 2020 also, she is also a member of ASFMS and she's a vice chairman as per my knowledge. So a very, very warm welcome, Dr. Dema. Just a second, So besides that, I want to welcome all of the friends who have joined all across the geography. I always believe in the concept that knowledge is always increases by sharing, and knowledge is not limited to the boundaries. With this motto, I initiated this series, The Icons in Conversation with Dr. Ritu. This is a knowledge sharing global forum. Till now, I have done too many sessions and all the sessions are very, very highly appreciated. And I'm really thankful to all of my friends, especially my international friends, who are very readily, in spite of having their busy schedule, they are ready to accept my invitation for knowledge sharing. So today, Dr. Dema is going to share with us a very, very important topic, the RH incompatibility and MCA Doppler. So a very, very warm welcome once again. In the Hindi language, Dr. Dema, we say like this, Namaste, Atiti Devo Bhav. That means guests are like God. So now over to you.
Namaste to all your friends. So it's welcome to see you. Let us share my screen.
Yes,
okay.
Yes,
it's good.
Yes.
My topic
Dr. Dima, your voice is breaking. Voice.
Now is the RH incompatible voice now good? Now good?
Yeah, now it's better.
Yeah. These are the reference with the pathogenesis of RH isoimmunization. We have the woman which is negative woman married to RH positive man, and the fetus are RH positive fetus. Red blood cells of the fetus cannot cross the placenta to the maternal circulation except in.
Sorry to interrupt you, Dr. Dima. No, voice is not clear. Huh? So can you switch off your camera? That will clear your voice quality. Huh?
Okay.
And you can share your screen also. Slides are also not visible.
This is the good now. The voice
is clear, but slides are still not visible.
Now.
Yes, yes, now it's visible.
Okay, of RH isoimmunization, we have RH negative woman married with RH positive woman, and the fetus are RH positive fetus. Placenta except can cause the placenta in 27 weeks of gestation according to contraction after the separation of the placenta. And these red blood cells can cause the woman sensitized. Sensitized, it means that produce the immunoglobulin. Immunoglobulin, which is especially in RH, is the type of these immunoglobulins are immunoglobulin IgG, which can cross the placenta to the in another pregnancy. We have the second pregnancy. These immunoglobulins can cross the placenta and cause to hemolysis in the fetus. As we all know, when the father are homogeneous, all the children are RH positive, and if the father are heterogeneous, the 15% of the children are RH positive. Okay, this RH negative woman carry RH positive. This RH positive
Dr. Dima, sorry to interrupt you. I think we are not able to hear you.
Development of RH can cross the placenta as I said. Good. The voice is not good, doctor?
No, voice is not good.
Now is
no, still not
better now.
No, still not clear.
Still not good?
No.
I think
by internet is, I think, creating a problem.
Yeah, I opened 4G for this occasion, but I don't know what's the problem.
Now voice is clear. Now it's coming clear.
Yeah, come clear. Okay. Okay. Then in this pregnancy, this immunoglobulin destroy the red blood cells of the fetus and cause hemolysis in the fetus, and which can increase the indirect bilirubin. Indirect bilirubin can cross the placenta by and can be
Dr. Dima, so sorry. So sorry. We are not able to hear you.
To direct bilirubin by the liver of the mother. But there are increase in indirect.
Sorry to interrupt you. We are not able to hear you.
In the amnios 15. I don't know which.
Because your slides are also not. Dr. Dima, will you rejoin again? Will you rejoin again? You will disconnect and can you join again? Because voice is not clear. So many comments we are getting, voice is not coming clear, and your slides are also not visible.
Okay, I will try.
Okay.
Yeah,
okay. Yeah. Dr. Beena, she has joined only from one device only. Friends, please be with us. She is joining. Dr. Dima is joining very shortly. Too good to see so many of my friends have joined. Hi, Jyoti. Hi, Shama. How are you? Yeah, good to see Suman Mittal, madam also. Madam, a very, very good evening. A very, very warm regards. Hi, Shama.
Hi, ma'am.
How are you, Shama?
Yeah, fine, ma'am. How are you, ma'am?
Yeah, fine, dear. Thank you so much. Meanwhile, friends, if you're having any queries related to RH incompatibility, please write down in the chat box. As soon as she will finish the presentation, we will take the live question answers. Yeah, hi, Dr. Rosie. Good to see you. Let me call.
Now it's better, doctor?
Yes, Dr. Dima. Yeah. Only please start sharing your screen. Yes. Perfect.
Yeah.
Yeah.
Yeah, it's better. Better voice? Okay.
Yes. Better voice.
Okay.
Yeah.
Yeah. We here when the hemolysis can happen to the fetus, and the indirect bilirubin increase amniotic fluid and placenta, which can convert to direct bilirubin by the maternal liver. But we can detect the increase of the bilirubin by by a delta OG 450. Now, on the disease can cause the heart failure of the fetus, which can cause the pleural effusions, the scalp edema, and ascites, the character of fetal hydrops, as we all know. And this fetus, which is hydrops. The problem is not in the pregnancy, but may become the problem, neurological problem after the delivery because of the jaundice, because the indirect bilirubin convert to direct bilirubin dependent neonate, because this is suffering from two problems. We made the heart failure on a neurological problem.
Slides are not visible.
I share it.
No, slides are not visible.
Now is
no.
No voice also?
Voice is now coming, but slides are not visible.
Now,
yes, now slides are visible.
Now,
no, not visible. Not visible.
Yeah, the management of sensitized.
No, not visible.
The problem.
Not visible. Slides are not visible.
Now
visible. No, again now not visible. Chitra, can you help little bit?
Madam, can you please unshare your screen and again you can share your screen? Yes, now slide is visible. Can you make it?
No slide is visible now?
No.
Yes,
no.
but again.
Now visible. Now visible.
Good?
Yeah.
The answer is the good. Yeah. Is there the correlation between the titer of the immunoglobulin and the severity of the disease? We found that the correlation between the titer and the severity of the disease is are poor, because we don't know how many of these immunoglobulin can cross really the placenta. It means that maybe
again not visible. Again, so sorry, again not visible.
Now.
No, Dr. Rima, is it possible for you can mail the slides to Chitrakala ID from where you got the mail? So she can show the slide and you can read. I think there's some problem, or you can stop sharing and again start sharing.
Ma'am, Chitra here, ma'am.
Hi. Yeah, Chitra, please guide her, Dr. Dima. Please guide
Sure,
Dr.
Ma'am, can you please stop share once?
Yeah, stop sharing.
Yeah.
Stop
yes,
sharing. Yeah.
Now you make your PPT in the presentation mode, ma'am.
And read.
Now please share the screen, ma'am. While sharing the screen, don't click on any icon except to share.
Now,
Ma'am, just it started, ma'am. Just okay.
better now.
Ma'am, can you make it in slideshow mode? No, ma'am. You please stop share. It will not come now also.
Yeah.
Now you please click the green color share icon.
Yeah.
Then don't click any icon on the screen. Just click that blue color share.
Now, okay.
Just a minute, ma'am. Yes, ma'am. Now you make it a slideshow mode, ma'am.
Yeah.
Or your left hand side near to that percentage icon. 74% is
Good.
ma'am, I can't hear you
Can you
properly. Ma'am, that lower left side corner above the Bluetooth icon.
now is better?
No, ma'am, actually. Ma'am, that's what. While sharing, you should not click any icon, any PPT. Only green color share and blue color share. Don't choose the PPT. Don't choose any PPT icon. Stop share, share again. Don't choose anything and please share, ma'am.
The voice is good, doctor.
No, still not good.
Now good?
Voice is little breaking. I think net is giving us trouble today.
Good.
No.
Now?
No, nothing. Nothing we are able to say.
Ma'am, started just, yes, ma'am, but it is not on slideshow mode. Ma'am, can you mail, Suman sir, can you give your mail ID so that you can share from your end?
Yes, okay.
So now,
Yeah, you text to ma'am mail ID, your mail ID, so that she will share it to you.
I don't know what's the problem.
Otherwise, if we can, now it's okay. Now it's okay, Chitra. I think we can go ahead with this. So many doctors are waiting for this important presentation.
Okay, ma'am.
Yeah, Dr. Dima, please go ahead. Dr. Dima, please go ahead. Yeah. What happened?
Madam, I guess Madam left because of.
She will join again. Then okay, I will call her. I will call her.
It's good now, doctor?
Yeah,
Or
but
not?
yes, now it's good. Yeah. Yeah, please start, doctor. Yeah, we are able to hear you. Yeah.
Yeah. Okay. The point we stop it, that the correlation between the titer and the severity of disease is poor, because we don't know really how many of these immunoglobulin can cross the placenta. It means that maybe the little of the immunoglobulin and maybe the lot of the immunoglobulin and cannot cross the placenta. But the elevated of the antibody titer at the beginning of the pregnancy, or the rapid rise on this titer, or the rapid is exceed the one above 64 or greater, it may be significant for hemolytic disease to the fetus. Because of that, we use the Lilly curve. Lilly curve, which can divided into three parts. The zone 1, which can make amniocentesis by 1 week, by 1 month. And zone 2, we must repeat the amniocentesis every 2 weeks. And if the bilirubin can reach the zone 3, it means we need the intervention. We can start the amniocentesis after 27 weeks of gestation. Because of that, we are very late. Because of that, there are very better to do middle cerebral artery, which can maybe start to do in middle cerebral artery at 80 weeks of gestation. Because of that, we are too much earlier. And these can divided into many zones. In zone P and zone C, we must repeat it after 10 days. And in zone P, we must repeat it after 7 days. And if the middle cerebral artery in the zone A, we must do the intervention, which is intrauterine transfusion. Voice is good, doctor?
Yes.
Yeah. Middle cerebral artery is a non-invasive procedure, which is available in many machines and easy to repeat it. Need some experience, and also it's accepted test because it's not invasive. And these tests cannot don't decrease the immunoglobulin, which is the amniocentesis can be increase the immunoglobulin. The sensitivity and specificity of middle cerebral artery peak systolic velocity in detection the anemia is are better than amniocentesis can exceed 100%. And also there are better in the middle cerebral artery above the amniocentesis and detecting the bilirubin in some sensitized, some this can cause the fetal anemia. The problem is not hemolysis, but there is the anemia can cause by suppression the erythropoietin precursor in the bone marrow of the fetus. Because of that, the bilirubin doesn't increase in this case, but the middle cerebral artery can predict of the anemia better than amniocentesis. And also, the middle cerebral artery peak systolic velocity are reliable for the diagnosis of the fetal anemia in many causes, especially in parvovirus infection. Parvovirus infection, as we all know, is a viral infection. We can do middle cerebral artery every week for for 10 weeks following the exposure, and this infection cannot cause, maybe cause high drops, but can resolve spontaneously without needing any intervention. And we can also use the middle cerebral artery in twin-to-twin transfusion syndrome, and in the case of fetal-maternal hemorrhage and other causes of fetal high drops. These are the fetal circulation. We have the placenta, we have the umbilical vein, reach the left atrium, and the foramen ovale to the left right atrium, to the circle of Wells. Circle of Wells in the proximal point after the origin from internal carotid artery. And we can avoid the angle correlation of this sampling. We detect by detecting the gate in this point, and we have the waveform. We must have at least 3, as we see here, the peak systolic velocity of middle cerebral artery can reach 16 cm per second. Because of that, there are a recommendation of American College of Obstetrics and Gynecology to use the middle cerebral artery peak systolic velocity to the moderate or severe anemia. And there isn't must increase peak velocity according to the degrees of the hemoglobin in the fetus, because the velocity in the anemic fetus can increase in all artery of the fetus, but we detect especially the middle cerebral artery because we can able to reach it, and we can detect the zero of angle of inclination reach minus 13 degree. We can reach it from velocity. Okay, madam. Okay, we use this. We suspect the middle cerebral artery abnormal, which when increase 1.5 multiple of median according to the gestational age. And also, middle cerebral artery big systolic velocity can tell us how much of the anemia can be found as a mild anemia or moderate anemia or severe anemia. As we all see here, we can start it at 18 week of gestation. For example, if the fetus are 20 week of gestation, the middle cerebral artery doubling if the middle severe anemia, see here 13, when the middle cerebral artery exceeds the 16 cm per second, it means severe anemia. As we see here, we can find the chart which can tell us how cerebral artery and when is the suitable time for intervention, which is intrauterine transfusion. As we all see here, so, as we all see here, it's in this fetus in the zone A, and we make the transfusion, then the middle cerebral artery systolic velocity B and T with it. And also I want to say that intra-arterial transfusion is not one time. We can need it many times until reach the maturity of the fetus. And also there are a special chart for middle cerebral artery after the transfusion, because we are transfused the adult red cells, which the velocity. The end is that we can also do the direct. The intra-uterine transfusion week of gestation, because after 34 we can start it above the 18 weeks. We can do by repeated by 1 to 3 week interval. We use the O negative packed cells compatible with the mother and the fetus. We can give it intravascular, which is better. And if the fetus is high drops, we can transfuse intraperitoneum. And also, we must take care of lung maturity in this fetus. We give them the dexamethasone, and they must be very close observation of this fetus by cardiotocogram, by ultrasound, by biophysical profile. And we can repeat the transfusion when we need, and when we reach the lung maturity, we can deliver the fetus. This can tell us that much important points in the middle cerebral artery. Middle cerebral artery, we do this detection. The fetus mustn't move and don't do many pressure on the skull of the fetus, and we can reach the angle 0, don't breathe, and we can detect the big systolic velocity to detect the anemia, and we also detect the pulsatility index and the resistance index in the case of the IUGR. And when this big systolic velocity exceed 1.5 multiple of median, it means moderate or severe anemia. But we must take care of the sound effect or cavitation or of that, which is the thermal index of soft tissue. When exceed the 6, it means that we mustn't increase time of doing this procedure mustn't for the necessary to obtain the diagnostic information. And there are also the mechanical index as the FDA. It mustn't increase the 1.5 for the mechanical index, because of that we don't use the Doppler time 1 hour. There are also the advantage of middle cerebral artery in cases of the IUGR. The umbilical, as we all know, we do umbilical artery and the middle cerebral artery, which cerebral we minus the above the umbilical ratio between the peak systolic velocity, the pulsatility index of the the pulsatility index of middle cerebral artery and the pulsatility index of the umbilical artery. When the ratio is above the 1, it means normal. When minus 1, it means hypoxia or IGR. And thank you for your listening. I'm sorry for internet unstable. I hope this lecture is helpful to you, and I'm ready to answer the question.
Yeah.
I will stop sharing now.
Yeah. Thank you, Dr. Dima. Yes, of course, the lecture is very nice, but due to some internet connections, there is some problem. Yeah. So thank you so much. And we have received some questions. Yeah. You can also see on the chat box. I will read. This is one question we have received. Actually, this is not related to Doppler. It's a clinical question from Dr. Anupma. Yeah, hi, Dr. Anupma. Dr. Anupma is writing, if the patient comes in late in 9th month, can we give antepartum anti-D if indirect Coombs test is negative, or it is only after delivery? What protocol you follow, Dr. Dima?
Yeah. We give the anti-D to the non-sensitized women in 27 weeks of gestation because of the Braxton Hicks contraction. And also we give them the anti-D after the delivery. If there is a normal pregnancy doesn't need the anti-D. But in non-sensitized women, we must use the anti-D in every occasion we suspect the cross of the red cells to the maternal circulation. We can repeat it many times in the pregnancy. If the patient bleeding, we can give him the anti-D, and if there is the accident, we give anti-D. We do amniocentesis, we give anti-D. And if the normal pregnancy doesn't mean any problem, we give them the immunoglobulin, the anti-D, and 27 weeks of gestation. And after the delivery, according to the Klein-Hour test. Klein-Hour test means how many of these red blood cells cross the placenta. It means we must give them the anti-D to destroy all the red cells across the placenta. If the 10 red blood cells cross the placenta and we give, it means we don't give them the suitable amount. And this patient, although of take from non-sensitized to sensitized women.
Yeah. Thank you, Dr. Dima. Dr. Anupma, I think you got the answer. I think she's asking the question if the pregnant patient is approaching directly on the 9th month and if IDCT is negative. So there are not clear-cut guidelines regarding to this, Dr. Anupma, but of course it's better to be safe. So if you can give, that is no harm. Yeah. There is another question from Dr. Selvi. She is asking for the titer level for the cutoff is 1:8 or 1:16. So what protocol you follow, Dr. Dima?
1:16. It means must follow this the logarithm of sensitized women. We must begin from 18 weeks of gestation to detect the middle cerebral artery and continue as the zone of middle cerebral artery, in which zone we are. If there is the must do the intra-transfer exceed the 1.5 multiple of median, it means severe anemia. Then we must intervention, not according to the.
Yeah, okay, thank you. I will take one more question. Yeah, this is we have received on the YouTube.
This is the point we don't.
Sorry, your voice is breaking again, Dr. Dima. Voice is breaking.
Can you read the question, please? I don't see it.
Yeah. I will read. Yeah. That is, can only the middle cerebral artery peak flow velocity measures the presence or absence of fetal anemia, or any other further test you recommend? I will repeat. Can only the middle cerebral artery are you able to hear, Dr. Dima? Actually, Dr. Dima has already covered this all in the presentation. Dr. Dima, are you able to hear us? Are you able to hear us? I think we will wind up for the today's session because net is creating.
The last question, because I cannot.
That was the same question you have already answered. You have already answered the same question. Yeah. So you can see there is one more question from Dr. Saifuddin Abdullah. Are you able to see in the chat box? Dr. Saifuddin is writing that which is better to use, the Lilly chart or
the question?
Yeah. Which is better to use, the Lilly chart or MCA PCV Doppler?
As we mentioned the lecture, that the middle cerebral artery peak systolic velocity sensitivity and specificity in detecting the fetal anemia is better than the amniocentesis and the Lilly chart. And can reach the charts mean we need to do the amniocentesis, which is invasive procedures, but the middle cerebral artery, ultrasound would not harm the mother also, and not increase the antibodies. So it's a very important point in these mothers, because in every amniocentesis we can some red blood cells cross across the maternal circulation and cause the increases in the antibody sensitization in the woman.
With this, we will wind up for today. So thank you so much, Dr. Dima, for your very extensive and good presentation. That is very, very useful for all of us. I think we will do once again this program, because today the net is creating a lot of problem. So with this, we will wind up for the today. So thank you, friends, also who all have joined. And with this, we will wind off. Bye-bye. Good night. Stay safe, stay healthy. Thank you. Thank you, Dr. Dima. Thank you, Chitra, too. And Dr. Suman, and she'll connect.
Thank you very much. Thank you very much all for joining.